Good afternoon. This is a courtesy announcement that this meeting is now broadcast live on YouTube and our web portal.
Welcome, Christine. Would you like to do a mic check?
Yes.
Sounds great. And I see your video too. Thank you very much.
Great. Thank you.
Welcome, Dr. Smith. Would you like to do a mic check?
Yes, can you hear me?
Sure can. Thank you.
Okay, thanks a lot.
Welcome, Tyler. Would you like to do a mic check?
Happy to do that. Can you hear me okay?
Sure can. Thank you.
Tyler, if you'd like to do a quick screen share practice, you can. If you feel comfortable, you don't have to.
Do you see it?
I do. I'm not sure if you want to expand it a little more, but that certainly serves our purposes.
How's that?
Great. That's great.
All right.
Thank you.
Welcome, Supervisor Simitian.
Hi, this is a sound check, loud and clear.
Sounds great.
Thank you so much.
Beth Jameson will be your clerk today.
I'm sorry, I could not hear that. Would you repeat, please?
Yes, Jess Jameson is your clerk today.
Thank you, Jess.
Good afternoon. You're welcome.
And Jess, why don't you go ahead and start us live here in a minute and just let us know when, please.
Recording in progress.
Okay, I have 30 seconds to 2 and your recordings are live.
Thank you so much. All right, ladies and gentlemen, it is 2 o'clock and it is time for our Santa Clara County Health and Hospital Committee to come to order. First item of business is the call to order, and that entails a roll call. So we'll ask the clerk, please call the roll and establish the presence of a quorum.
Vice Chairperson Lee,
Lee present.
Chairperson Simidian.
Simidian, present. Thank you. All right, both members of the committee are present. Takes us to item number 2, which is public comment. That is the portion of our agenda set aside for comment by members of the public on non-agendized items, items that are not on today's agenda, but that are properly within the jurisdiction of the Health and Hospital Committee. Let me check with the clerk and see if we have any requests to speak under public comment.
I have one request at this time.
All right, let's go ahead and allow 3 minutes, and then once that time has expired, anyone who has not yet asked to speak under public comment, I'm afraid will have to pass, but we'll let anyone else who might like to speak under public comment sign in during that 3 minutes. Let's go to our one and only speaker, at least for the moment.
Thank you. Our first speaker is Paul Soto. I have unmuted you. You'll have 3 minutes to speak. The timer will start when you begin speaking.
Good afternoon, supervisors. Paul Soto from the Horseshoe. The reason why I'm here is that there was, during the 90s and 2000s, there was the reason why we had Plata versus Brown, which is the legal argument written by Justice Anthony Kennedy that allowed the realignment, that allowed the reentry programs and everything that flowed from that. One of the reasons why that was is that in that document, it was cataloged, it was documented that there was 1 person per week dying in CDC as a result of medical neglect. They did the research and they attributed that death to medical neglect. And there was 1 per week. Now, I experienced 3 of those. 2 of them lived on the right-hand side of me. 1 of them lived on the left. And I heard and watched these men die, literally. And this was during a time when the rhetoric on the street was lock them up, throw away the key. This is the Deukmejian, Pete Wilson, Dan Lundgren years. And so when the gentleman passed recently in the county jail of COVID, I was impacted by that because I understood what that meant. Because the worst fear that an inmate has in there, because there is no power. We exercise no power. We can't advocate for ourselves because it's still going to be arbitrarily determined whether or not the contention is worthy. And so that sense of powerlessness and helplessness and complete, just you're literally at the mercy of whether or not this dude wants to participate in your life or not. Yet they are paid well to do that. And so it just brought up like a lot of things. And so I wanted to come to this meeting and to just state that how important your work is, because as soon as somebody has cuffs on them and they are placed within your custody and you accept them into that jail, this person's life, their entire 100% your responsibility, 100%, you know, and you just, I've just spent like way too much time there, and I've seen where that was not the case. One thing that I wanted to say is that throughout this whole journey of the jails and everything, I am thoroughly impressed by what it is that you've been able to do, Supervisor Simidian. Very, very impressed. Thank you.
That concludes our requests.
Thank you, Madam Clerk. We'll go on to item number 3 then, which is to approve the consent calendar and any changes to the committee agenda. We do have a proposed consent calendar, which is items 13 through 19. Supervisor Lee, might I ask you for a motion to approve the consent calendar as contained in our published agenda?
Yes, so moved.
Thank you, Supervisor. I will second. I will just note that I've been advised that item 15, which deals with legislative policies, may come to our board with some amendments as it moves through the system. I want to acknowledge that. And as always, I'll indicate that whenever we vote to support a particular set of legislative policies, that doesn't mean that any individual supervisor necessarily agrees with each and every one of them. That being said, all we're being asked to do today is receive the reports. So we have a motion from Supervisor Lee, a second from me, to approve the consent calendar as contained in our published agenda, items 13 to 19. Let me ask the clerk, do we have anyone who would like to speak on the consent calendar?
I do have one request.
All right, let's go ahead and give that person 2 minutes. And if there are others who sign on during that 2 minutes, we will certainly accommodate them. But we will say after that, we will have to cut it off. Go right ahead, please. Next speaker.
Thank you. Our first speaker is Paul Soto. You'll have 2 minutes to speak. Please go ahead.
Thank you, Paul Soto from the Horseshoe. I have item number 17, working partnerships, USA relating to healthcare reform. The very definition of conflict of interest is when someone makes a decision on a policy or a somebody that is bringing something to the table, and they are literally the architect of that particular organization. Now, what's I see happening is that because this is allowed and there's no ethical flag that's raised, it normalizes something that actually should be checked before it gets to this level. And so there's a problem there. There's a very big problem, because there's a like almost like a normalized baked-in incentive for that to continue, because no one's checking it. And so, because I don't work for no nonprofit, I don't get paid a dime to do what I do, and I spend probably about 50, 60 hours a week doing it, is that I can talk freely and openly like this and call things out like that. And I'm really concerned about it. I want to know why that does not trigger in the board's mind, or even in their moral compass, that why it does not raise ethical questions with regard to Supervisor Chavez voting on anything that has to do with working partnerships. Thank you.
All right, let me confirm with the clerk. We have no other speakers on item 3.
Correct.
Then I will say thank you to the speaker who did participate, and we will ask for a call of the roll on item number 3, which is to approve the consent calendar and changes to our agenda.
Vice Chairperson Lee,
Aye.
Chairperson Smidian.
Aye. Motion is approved unanimously. It takes us to item number 4. Item number 4 is to review the VMC, or Santa Clara Valley Medical Center staff and allied health professionals, various appointments, reappointments, and privilege actions as contained in our published agenda in item number 4. And let me see if we're going to turn, we are, to Dr. Karanis. Welcome, and what would you like us to know today before we ask for a motion, Doctor?
Thank you very much. My name is Yvonne Karanis. I'm the president of the medical staff for Santa Clara Valley Medical Center, O'Connor, and St. Louis Regional Hospital. I'm here to ask for approval for our credentials report, as well as for our enterprise privileges in pathology and laboratory, and our revised pediatric nurse practitioner privilege set. Happy to answer any questions as well.
Thank you. Supervisor Lee, questions or a motion?
No questions, and ready to move. So moved.
All right. Supervisor Lee moves approval of the recommended action as contained in our published agenda for item number 4. I'm happy to second. Let me check with the clerk to see if we have any speakers on this item.
No.
Then I'll call for the roll, please.
Vice Chairperson Lee,
Aye.
Chairperson Smidian.
Aye. Motion carries unanimously. Thank you very much, Dr. Karanis. We're able to carry on with your good work for another month. Take care.
Thank you so much. And on behalf of the medical staff, I'd just like to thank the Board of Supervisors for your support of the medical staff, and to wish you a happy holidays and a wonderful 2022. Thank you.
Back at you. Take care.
Thank you.
All right, that takes us to item number 5. Item number 5 is, I want to make sure I call it out correctly from our published agenda, to receive the report from the Facilities and Fleet Department regarding, and the Santa Clara Valley Medical Center and the Office of the County Executive relating to the Child and Adolescent Psychiatric Facility and the Behavioral Health Service Center on the Santa Clara County VMC campus, which was scheduled to open fall of 2023, and therein lies the challenge. So let me see first if there's a presentation from staff.
Good afternoon, Supervisor Smitty and Supervisor Reed. Doug Koenig, Deputy Director for Capital Programs. As an update to the report, staff did serve notice to XL Construction that we would be terminating their contract for convenience. They received that notice this week. Our plan now is to bid out or solicit bids for new general contractors just as soon as the complete construction document package is ready. Per HGA, they are still on schedule to do that by the middle of February of next year. We have a draft schedule which projects if we go down this path, we will achieve occupancy of the new BHSC by the end of 2024. It's an ambitious schedule, but it's still approximately 5 months ahead of what XL is currently proposing and never did commit to. There's risks associated with it, the biggest being that there's no guarantee that we will receive responsive and responsible bids when we do go out for the solicitation. Are there any questions?
No, thank you. Supervisor Lee, before I turn to you, I should just indicate how I would like to proceed, Supervisor Lee, and if you'd like to, I'm happy to make a motion to that effect and ask for your second when the time comes. I want to make sure that Ms. Sola from the Harvey Rose organization is in the meeting and available to speak. Ms. Sola, are you with us, please?
Yes, sir.
Thank you. Supervisor Lee and others, let me just express my continued disappointment at the way the timeline has been represented to our board, this committee, and to me personally. In this is a conversation that has been underway now for 7 years since I first confronted the absence of what we have come to call in shorthand teen beds, acute care beds for teenagers in severe emotional and mental health crisis. We had, during the course of the year 2019, so a series of quarterly meetings with Dr. Smith and his team to discuss the schedule, and we were, my office and I were assured that we were on track, things were moving along on a timely basis, and that the best estimate was that the project would be complete in the fall of 2023. I want to make sure I get my dates right here. And then as we moved into the beginning of 2020, we were advised in writing that, in fact, that 2023 date was not still projected, operative, effective, whatever, notwithstanding the quarterly assurances we had been given by staff in my office. And so I then began the somewhat painful practice of asking for a report on a monthly basis. And in the 18 monthly reports that followed, or at least 18, a year and a half, every month we would go through the exercise of taking a look at the flow chart, like the one we have in today's packet. And I would note that it said the project was going to be wrapped up in November of 2023, and ask if we were still on track for that. and was assured by the county executive and his team that we were in fact still on track for that November 2023 completion date. Then, as you will recall, at our most recent meeting in November, that 2023 date was extended by 13 months, meaning that after being told every month for a year and a half that it was going to be ready to go in November of 2023, we were suddenly being told, no, actually the date is December of 2024, 13 months later. And while some of that was attributable to potential delays with about 6 weeks, Supervisor Lee, you will recall that at the last meeting, you observed that 13-month delay. And that has left me struggling to determine just how we can stay on top of the construction completion dates when the assurances we have been given have been repeatedly wide of the mark. I'll let it go at that. So I'm having some internet problems here. Supervisor Lee, can you still hear me loud and clear since I'm about to ask for a second to a motion?
Yes, I can hear you now. Thank you.
Thank you. Maybe what I'll do is I'll get rid of my camera and see if that improves the quality. So Supervisor Lee, what I have pursued as an alternative approach is a conversation with the Harvey Rose organization led by Ms. Soloff through their existing contract, since we have a contract with the Rose organization, and they have the ability to hire on a subcontractor, someone with construction audit expertise. I have asked them to both commence that process, meaning to look within their own organization, and then rather necessarily look beyond their own organization to find someone who could serve as a independent construction auditor who will essentially monitor the progress or lack thereof on the part of the county and its contractor and report to us on a monthly basis what the progress is or isn't and what a reasonable expectation of the completion date might be. I've asked Ms. Solov if she could essentially begin that effort now pursuant to an individual board member's request, which the contract permits, and with the notion that she would bring a contract amendment or direction, whatever the appropriate vehicle is, to our first meeting in January 11th, to formalize and effectuate that. So I'm going to move that we provide that direction to the Harvey Rose organization, ask you for a second, and then open it up for some discussion, starting with Ms. Soloff. Can I get a second from you, Supervisor Lee?
Yes, happy to second.
Thank you. Ms. Soloff, how does that sound? And please feel free to clarify or untangle anything that I might have tangled in the retelling of all that.
Thank you, Supervisor. We have attempted to reach out to some firms, and thus far we have not identified anyone yet, but we are still continuing to search. So with that said, I don't know that we would necessarily have somebody on board on January 11th, but we will endeavor to make this happen.
Thank you, Ms. Soloff. Even if you don't have, excuse the interruption, even if you don't have somebody, quote, on board by the 11th, I would like to make sure that the direction provides clarity about our expectation that you will have something on the agenda on the 11th, because ultimately this is something we'll want the full board to be aware of and to consider and take formal action on. So you're getting direction from a vote by virtue of a vote of the entire board. Does that sound right to you?
Yes.
All right. And if you don't know today, that's okay. But if you do, would you anticipate, is this direction within the existing contract? Is it a supplement to the contract? What do you think? Is it too soon to know how it'll be structured? Do you want to give that some more thought?
I think it would need to be an amendment or a supplemental.
Okay, well, we've got a motion and a second. Let me see, Dr. Smith, do you or your team want to weigh in on this at all?
No, I don't really have anything to add to it. Thank you very much.
Thank you. Let me just confirm with the staff. We have issued bonds for this project, if I remember correctly, yes?
Yes.
And which means that we are, quote, committed to the project since we've asked people for money to build it, yes?
We are committed to the project.
Okay,
Yes, indeed. We're under contractual responsibilities with our bondholders to build the project.
okay. Then let's see if there are any questions or comments from Supervisor Lee. Go to the public for comments, if any, and then we'll go to a vote.
Sure, a couple of questions. First of all, based on where we are right now, as staff has proposed, the demolition, is that going to be continuing to be carried out by Excel Construction?
This is Jeff Draper. No, Supervisor, it will not.
It will not, right? So basically, we'll end it before them actually even breaking the first wall, whatnot, right? So this, we're going to take that away from them. So,
That's correct.
All right, thank you. And I just want to say thank you to Supervisor Simian for coming up with a very innovative idea. You know, a lot of times when it comes to these type of project, I think it's something that we generally rely on staff to do. But this is one of those cases where it gets to a point we're really seeing a lot of resistance, maybe due to inflation, maybe due to lack of labor, maybe due to all kinds of other outside reasons why things are being delayed and that our contractor is not able to move forward. Usually we see things that they have these increases of estimates and whatnot. In this case here, it's not even that. It's just basically like we can build it for another year at the very least. So certainly this is very disappointing, and the need for this type of facility, I don't think we need to, for adolescents and adult for deep behavioral health facility, something that's long overdue. And so there's certainly a very serious urgency. We need to do this. So by having the appointment of a independent auditor to keep this thing pushing, I think would be very, very helpful. And somebody who can have the expertise and the bandwidth to keep the nudge on. So I really do think this is hopefully a way to, basically, we're not trying to fault anybody at this point other than the fact that we really want this thing built as soon as possible and not push any later to late 2024 or even later. So I definitely will be supporting this. Thank you.
Thank you, Supervisor Lee. Let me ask the clerk if we have any further comment from members of the public.
I have one request.
Let's go ahead and give that speaker 2 minutes, please.
Thank you. Our first speaker is Paul Soto. You'll have 2 minutes to speak. Please go ahead.
Thank you, Paul Soto from the Horseshoe. I did not know that a facility like this was being built. I spent a lot of time with the city, and so I'm out of the loop on county matters. So I don't know if you could, but if you would extend a courtesy and just letting me know where I can go and find out I want to know everything about the facility. How was capacity determined? Like who put the the limit on terms of the capacity, and how did they arrive at that? And then what is the anticipated, like at this point it's being built. This county has never had a facility like that. It was EPS, that was it, Emborg. And so I'm curious, is like, what is the kind of expectation around it? Because we've needed it for decades, but at this point in time is when the impetus is viable now. And so I'm just very curious about that. That's all I have. If you can provide the space where I can do my own research. Thank you.
Thank you. Thank you to the clerk. Thank you to
I
the
do have-
speaker.
Apologies, I do have one more request to speak.
All right, let's go ahead and accommodate that speaker as well then, please.
Our next speaker is Mike Rogers. You'll have 2 minutes to speak. Please go ahead.
Good afternoon, supervisors and staff. Just a quick question. To understand that the county is now looking for a new general to actually execute this project and its construction. It's a quick question. If that is true, I might have a couple of people that I could point your direction, but I was just curious listening in on the rest of the committee meeting. Thanks for your time.
Thank you, Mr. Rogers. Mr. Draper, ordinarily, we don't go back and forth and do question and answer, of course, but you did cover that relatively quickly. And so I think it is probably helpful both for the committee and the folks at the county and the public if you just sort of say, tell us again, and I think it was Mr. Draper, forgive me, if it was another member of the team, where we are with XL and how we plan to proceed from here.
Happy to do so, Supervisor.
Jeff,
And
you
I'm
muted
sorry.
yourself.
Hello, everyone. This is Jeff Draper from Facilities and Fleet Department. Thank you to Supervisor Midian for the question. Yes, we will be looking for new contractors. We hope to go out in a February timeframe for a new general contractor to actually perform the construction on this project.
And Mr. Draper, just to clarify, meanwhile, the work that XL has been doing to get us construction ready will continue, yes?
Yes, that is the plan.
All
And
right,
that's what
thank
we're
you.
doing.
Okay, thank you. Then I think, let me just confirm with the clerk, I think that was our last speaker and we're ready for a roll call vote.
Correct. Vice Chairperson Lee,
Lee, aye.
Chairperson Simidian.
Aye. Thank you very much. The motion carries unanimously. That takes us to item number 6, which is our COVID report. So let's turn to the folks at Public Health and see what they would like to share with us today.
Good afternoon, Supervisor Simidian and Lee. This is Dr. Sarah Cody from Public Health. And I just have 5 quick slides. I wanted to update you on where we are with the pandemic, a bit of an Omicron update, and a bit of a vaccination update. So if I could have the first slide. The first slide shows us, as always, where we are in the pandemic. These are the cases per day with a 7-day rolling average. And if you look out there way to the right, you can see the course is getting a little bit bumpy, but we are, that little dip right there is probably reflects less testing over the Thanksgiving weekend. But I think in general, we may be seeing a gradual rise with a bumpy course. As time goes on, the cases will be, case counts will be more and more difficult to interpret as we anticipate that more people will be using home testing. And of course, results from home testing don't get reported to us. Next slide. So I'm going to spend 2 slides with just an update on Omicron. And this is, the information about Omicron is evolving very rapidly. So it's somewhat reminiscent of how we felt in early 2020, in that at that time, lots was happening in internationally before it happened in the United States. And we looked for international trends to help us understand what we may experience with time. So what we're seeing now is that in some places, Omicron is growing very quickly. I use the word explosive. I hope that's not too much of an overstatement, but in the United Kingdom, Norway, and Denmark, they're seeing really, really significant growth. And I think it was reported, I think it was yesterday, that the Omicron is now the dominant strain in London. In Norway, they had a Christmas party just after Thanksgiving, where the many of the people at the party, the vast majority of them became ill, very high attack rate, and now they're seeing cases grow very rapidly. Same in Denmark. And just I want to note that Norway and Denmark are countries, they're small, they're still larger than our county, but they're highly vaccinated, and they're seeing significant transmission even in a highly vaccinated population. So in the United States, we now have had Omicron detections in a majority of the states. It changes so quickly that I don't have an exact number for you. Some of these, of course, are imported cases in people who are traveled, but more and more we're learning about spread within the United States. So evidence of community transmission. And in some parts of the country, in the Northeast, we're seeing explosive growth there. And indeed, I've recently learned through the news that some colleges in the Northeast have closed their campuses out of concern for the rapid growth and are completing the semester remotely. In California, as of December 8th, there were 13 cases. I know that's quite an undercount, but I was not able to find the exact number of reported cases in the state. In Santa Clara County, just 4 confirmed so far, but we have many that we are investigating. And so I anticipate that number is going to grow rather quickly. I also want to note that all 4, in addition to doing surveillance, are looking for the Omicron in people who have the infection. We also look for it in our sewer sheds, as I think you may know, and all 4 of the sewer sheds in our county have had an Omicron detection. They're looking for a marker for Omicron, and it has been found in all 4 sewer sheds. So it is here. As far as how this new variant behaves, we are still learning every day, but I wanted to share a little bit about what we know so far. So key question is transmissibility. It's not completely clear yet, but the evidence is growing by the day that Omicron is indeed very transmissible, that it may spread more easily than other variants that we have experienced. And that's very, very important. The severity of illness that it causes, still not clear. We're hearing a number of reports that illnesses tend to be mild, but we still don't know, for example, of 100 people with symptomatic illness or with infection of any kind, what proportion of them will have illness that's severe enough to require hospitalization. That's still unclear, but I think the point that I really want to get across is that if it's more transmissible and the cases grow quickly, as they seem to be in other parts of the world, even a very small proportion of a very large number can be enough people requiring hospitalizations that it can exert significant stress on the healthcare delivery system. And that is why we are anxious about what seems to be a virus that's spreading so easily. As far as protection from prior infection or from vaccination, there are lab studies that show that prior infection with the alpha variant, beta or delta variant doesn't seem to provide much protection against Omicron. So again, I want to emphasize these are mostly lab studies that we're looking at, but you're looking for antibody that you got from a previous infection, and does that help you when your body then sees Omicron? And it looks like not so much. As far as vaccination, we know that we've seen a lot of breakthrough infections with the Delta variant, which is why for the last month we've been urging those who are eligible to get boosters. It looks like that is also the case with Omicron. So for example, the cluster that I mentioned in Norway, this was a Christmas party of 100 some odd people. All of them were vaccinated, and someone obviously had Omicron and didn't know it, and 80 some odd of them got infected and all had been vaccinated. To date, we've not heard that any of them are very ill. But what this really does is underscore the fact that the primary vaccination series isn't enough anymore because the virus is changing and evolving. And so it's more important than ever to get a booster shot, and that boosts your level of immunity back up again to reduce the chance that you get infected and also reduce the chance that you develop severe illness. So the other question is, will this Omicron variant outcompete the Delta variant that we're seeing all over the world right now? And that does seem to be likely. So as I mentioned, that's what's happening in the UK right now. And in London, it seems that Omicron has overtaken Delta, so as an example. So these are concerning features that we are learning about and that are developing. So in the next slide, I want to just talk again about, so what do? We have been experiencing uncertainty and change for 2 years now, but we've also learned a lot. And to the very best of our knowledge, the recommendations remain pretty similar to what we've been recommending at past times in the pandemic. And that is to think about each layer of prevention. A single layer is never enough. They have to be, one layer has to be combined with another to provide adequate protection. So vaccination, we now know that 2 doses is no longer enough to prevent infection, and therefore boosters are needed. And we are really urging everyone to get their booster as soon as possible because we anticipate that there'll be extra travel and gatherings over the holiday. So get boosted now. Masking, particularly important, especially indoors. And as you know, we have required masking indoors in our county since August. Effective today, there is now also a statewide indoor mask mandate. We're recommending testing, particularly before and after travel, staying in well-ventilated spaces if you are gathering with people outside of your household, and distancing. And I think that the distancing, it's not just keeping a distance, but it's also thinking about size, how many people are you with, and for how long will you be with them, and limiting those to the extent possible. But 2 years into the pandemic, I think that this is still about living with uncertainty and balancing your individual risks and benefit, and that can look different for different people. Next slide. I wanted to update you with where we are with vaccinations. This is a screenshot from yesterday. As of today, we are now at 80% of residents in our county of all ages fully vaccinated. So with 2 doses of an mRNA vaccine or a single dose of J&J, 80%, which is an extraordinary accomplishment. And you can see there in purple the number of residents with a booster dose. So we now have over 500,000 with a booster dose. And you can see that that's begun to tick up in November. And finally, in the next slide, this is an update of where county residents are receiving their doses. So this is all doses by week by provider up through December 11th. And so if you look there towards the right, you can see that for the last 2 weeks there, the county health system has provided more doses than any other system, followed by retail pharmacies. And prior to that, retail pharmacies had been doing more doses than any other system since May. That is all I have, and happy to answer questions. And I believe I have some other colleagues on, Dr. Kamal, if there are questions about vaccination that I can't answer.
Thank you, Dr. Cody and team. Let me go first to Supervisor Lee, see if he has comments or questions. Then I'll have a few, and then we'll see if there are comments from members of the public. Why don't I go to you first, Supervisor Lee? Go to it.
Thank you, President Wasserman, on this one, not Chair. First of all, Dr. Cody, thank you so much for the good news that now we have at least 80% of all our residents have so-called completed vaccinations, which is the good news. But the unfortunate bad news is that the false sense of security of the so-called fully vaccinated when it comes to the waning effectiveness, because of the fact that you have that plus the complacency of not wearing masks, is probably going to be a new enemy. So one of my first question I have is this definition of fully vaccination. Do you think there'll be a time we might need to readjust what fully vaccinated means and requiring booster shots as one of the requirements when people are eligible?
Yeah, so I think we have evidence now to know that two doses or a single dose of J&J is not enough to provide us the protection that we need, both from breakthrough infections as well as hospitalization and death. Whether there will be a formal change in the definition of, quote, fully vaccinated is a separate question. I don't, I think at the county level, it would be difficult to change the formal definition if it's not changed at the state or the CDC. But I do want to be clear, and I hear your concern that to be fully protected or get the most protection that you can, a booster is very, very, very important. 2 doses are not enough anymore.
Exactly. And I think that's where we need to, keep, this virus is keep changing on us, right? It's new.
That's
we're
right.
learning
That's
by
right.
day. And I think that's why we're doing the best we can. I know you definitely are, Dr. Cody, bless your heart. And I really do think that we need to reset expectations, right? The term vaccination, a lot of times people say, you're vaccinated, that means you're immune. Well, at this point, I think vaccination booster shots are less about immunity from COVID, but it's about significantly reducing the chance of getting severely sick, being hospitalized, or dying from it. I think that really might become the new message, is that COVID's going to be around us for a long time. And I hate to say it, but some of the people who does not believe in vaccinations, they see you get breakthrough. So what good is that? Your natural immunity will do it. Well, I think that's maybe based on some of the expectations that people have set up, saying, well, usually when you get a shot for immune for something like chickenpox or whatever, then you will not catch whatever that bad thing is. Well, in this case, I think we're learning that breakthrough is very, very especially Omicron. Like you said, in Norway, the experiment is that, or an experiment, 80-some people of 100, even though they're fully vaccinated, technically with the 2 shots, still caught it, right? And the fact that the transmissibility, I've read something that says is double that of Delta, if not more. And so a couple of things I'm looking at, and maybe I'm being too pessimistic, but it seems to me that it might become the dominant variant in our county, even though you only counted 4 cases. Because if you see what happened to London and other places, and that's internationally, we are in Santa Clara County, right? I really do think that the 4 cases is probably a significant another county, because we know that variant is here and is transmitting very quickly. So whether we need to encourage people to do more additional testing, and all that. So another question I have a follow-up on is regarding, I just read this, I'm not sure if it's even real these days on the news, so I won't check in with you. I read something that says that San Francisco is getting some type of exemption from the state mask mandates. It seems counterintuitive. Do you know why? Or if that's even a true fact?
So as you probably know, many counties in the Bay Area implemented local mask mandates requiring indoor masking. So most Bay Area counties have had those in place. some Bay Area counties had made exceptions. So for example, in San Francisco, if I understand correctly, if there's a small, stable group of fully vaccinated people gathering, they would be able to have an exception from wearing masks indoors. So when the state came with their mask mandate, some counties asked, do we need to change ours? Does this, you know, the stricter state one now supersede the local one? And my understanding is that the state mask mandate said, no, if you've already had a local mandate, you can continue to implement it as you have been. You don't need to change. I think that in Santa Clara County, we are keeping the mandate that we've had. Now that we know that people who have had 2 doses of vaccine are, if they're not boosted, there's still a chance of a breakthrough infection and being able to spread. To me, it does not make sense to have something like that. I think that the safer bet is to wear masks indoors, you know, as much as possible, except for, of course, that sometimes when you need to take your mask off to eat or drink.
Right, correct. There's some report about some of the companies like Pfizer is coming up with some oral pills, and I think they are very close to approval or just being approved. Do you know if those will likely become available soon, so that that's another way we could get these out to folks instead of just the normal vaccination?
Yeah, if Dr. Kamal is on, he may have something more up to the minute to share. Dr. Kamal, are you on?
Yes, thank you for the question, Supervisor Lee. So the agent that has been reviewed by the FDA's advisory committee is the Merck product, the Montelukast. It has not received final approval from the FDA yet. But one of the issues is that it appears to be around 30% effective in reducing the risk of severe disease, whereas the other product called Paxlovid from Pfizer appears in preliminary studies to be 89 to 90% effective. That second product has not yet even been reviewed by the FDA, and it may be that they're waiting to review that before issuing an EUA for either one. The state has sort of already started the pre-work as our county in terms of if and when this is approved, how we would distribute it, because we are anticipating that both these products or either one which gets approved is going to be fairly limited in supply. So we are looking at ways how to make sure that as soon as we can get our hands on any of these, we can get them into the hands of the right people. They are extremely sensitive in terms of how quickly they must be taken. They all must be taken within 5 days of onset of symptoms. So time is going to be of the essence. So we're trying to figure out a plan to allocate that. Got it.
Thank you, Doctor. Dr. Cody, I guess since we went through this year and a half ago, back in March 2020, regarding having to shelter in place, nobody ever wants to go back to that, certainly. But are there certain metrics that you're looking at right now if this Omicron is getting more prevalent and that more and more people catching it, and regarding, like, say, ICU rates, hospital rates, are there type of metrics that you're looking at that we might have to go through more stringent requirements moving forward?
Well, I think, as you said, our top concern is the hospital capacity, and it's not just COVID, of course, but we have the Delta variant, the Omicron variant. Now we anticipate is going to surge. Flu, we're not seeing a lot of flu yet, but we probably will. And I think that hospitals are quite busy already. So I think that the hospital capacity and the ICU capacity is what we will be watching most carefully. I think we are in a different place than we were in March 2020. And so my fervent hope is that our public will learn what's going on and adapt. Our community has been extraordinary. And I want everyone to understand that Omicron could pose a very significant threat, and we each may need to tighten up all of these prevention layers. And I hope that that is going to be adequate.
Right. I guess in my last question is, for the past couple of months, I've seen news reports saying certain states like Idaho and some of the neighboring states where they have a spike to the point where the ICU capacity has been affected, but eventually I think it got a little bit better. Have we received any of those requests where folks want to transfer some of the patients to our system?
Not to my knowledge, although of course we do have that those systems in place so that other regions can ask for help if they need help.
Great. All right. Well, thank you very much, Dr. Cody, and for your team for your good work. Thank you.
Thank you.
Thank you, Dr. Cody. I do see we have a hand raised from Mr. Press in County Counsel's office. Mr. Press, why don't I go to you before I weigh in? And apologies that I am not visually live. We had some tech challenges earlier with bandwidth, apparently. Mr. Press, what would you like to share?
Just very slightly expound upon something that Dr. Cody had mentioned in reference to the interplay between local health orders and the state's recent health order. They issued a set of FAQs, I believe the following day after they issued their new order. And in the FAQs, in talking about local health jurisdiction orders, they say this: for local health jurisdictions that had pre-existing masking requirements, irrespective of vaccine status, in indoor public settings prior to December 13, 2021, those local health orders continue to apply. So we meet all the criteria that the state has laid out. So while we don't have sort of a definitive opinion from the state, that I think would be certainly a fair read at this point.
Got it. All right, thank you. And Dr. Cody, you're still with us, yes?
I am still here.
Thanks. There are 1,000,001 ways to slice and dice the data. That's one of the things I've learned from listening to you and your team over the course of the last year and a half. But I too want to start with just a couple of observations. And again, we'll all pick the numbers that are most compelling for us. But in today's report, the number that just popped out off the page for me is, it's on page 5 of the PowerPoint, 91% of residents 12 and up with completed vaccination. I just think that's just really an extraordinary number, and congratulations and thanks all around. I am recalling those early days of vaccination shortages, and I think if we had said then, now, our expectations will get to 90+% for ages 12 and up with completed vaccinations, we all would have said, not sure that can be achieved. So really good on you and county residents for stepping up and understanding the importance of the vaccination, and the various partners who have been delivering vaccinations during the past 18 months. And not in today's presentation, but in the presentation, I believe from just yesterday, I've got a series of PowerPoints here, but I am also so pleased that the very deliberate actions of the county to reduce disparities between and among various racial and ethnic groups in the county has paid off. I'm looking at a prior PowerPoint that indicates that the percentage with at least one dose was at that point, I think 73.4% for Caucasian and 72.1% for what's indicated as Hispanic and Latino residents. And, when you're literally just a point, 0.3 away, given the gap that existed much earlier in the year. I think that shows that if you put the time and attention and resources to the effort, we can reduce those, almost eliminate those disparities. So thank you all around on both of those two accomplishments. I think they're both really quite significant. That being said, and I know I don't have to make a believer out of you, Dr. Cody, but I am still struggling, Dr. Smith, Dr. Cody, and anybody else in the team, with the low participation rate in terms of vaccines at Palo Alto Medical Foundation. And I'm looking, Dr. Cody, at the final slide in your deck today, and I've looked at some earlier decks as well. And if I look at page 6, where the PAMF Sutter number is indicated in what I'll call red, and I have to be a little bit careful because it's very similar to the Stanford number, which is different. But looking to the right-hand side of the display for November of 2021 and now the first half of December, I can barely, I'm literally squinting here at my end of the screen to find that red bar registering. That is unfortunately consistent with earlier presentations that provided the display in a somewhat different way, where left to right, we went from, the greatest number of vaccinations to the smallest. And unfortunately, Palo Alto Medical Foundation was down there at the right with the smallest number. It's a particular concern to me, and because I am North County and West Valley district representative, and of course that's an area that is heavily covered by the folks at Sutter/PAMF. And we've talked about this before, and I know I gave you a heads up yesterday. What's the status of getting more help from the folks at PAMF Sutter on boosters? You've made the case yet again today that I'm reading the materials, a booster is needed for everyone who is eligible. Urgent need for boosters. Tuesday, we hit the tragic 800,000 deaths in the United States number. It's a global pandemic. What does it take to get a local provider to step up on boosters? And just so you know, I'm current, literally an hour before this meeting, I hopped on the phone, got to the call center, and have to say it's a very good call center in my experience, to ask about appointments, and there was nothing available at either the Los Gatos or Mountain View PAMF facilities for the next month through January 15th, and of course nothing schedulable after that date. That is consistent with what I found when I called on December 1st. So thoughts, and I'm going to press a little bit here in a minute about whether or not a formal order from the public health officer, that would be you, is necessary to get folks to step up. So anyone?
Well, I think the data speak for themselves. These are data from the California Immunization Registry. They're not local data that we've collected. They're simply what's in the registry displayed by provider. And what's not displayed is the number of patients that each system is responsible for. But I think that it becomes even more problematic when you look at it within that frame. I have also heard many anecdotes similar to the one that you described. So recently I have reached out personally to deliver the message of extraordinary urgency with Omicron here in our community and the experience that we've seen internationally. And I think that this is really a moment where even if we have not been perfect in the past, we need to we need to all come together very, very, very fast. So if, you know, I don't know if others would have other comments. I'm a little bit perplexed as to why there hasn't been more just natural pressure from patients in the system who need these services. Sometimes that's a helpful way to deliver a message to an organization that they need to step up a bit.
Yeah, let me turn to Dr. Smith and get your take. And I have some very specific questions, and I understand they may not be answerable today, but I would like to see if we could get some very specific numbers soon. Dr. Smith, before I go to you and Dr. Cody, I do want to clarify the distinction between, and it's an important one, people who are on the front lines at PAMF and Sutter, you know, many of whom have just done yeoman's work. They've really, you know, gone above and beyond. And I want to make sure they understand that the appreciation is there for their efforts. The concern is with what appears to be a decision at the management or corporate level to simply limit the number of vaccinations that are available at a time when, as Dr. Cody's remarks suggest, that's really indefensible. Dr. Smith, your thoughts?
Yes, Supervisor, all very troublesome. And as you very well remember, when we started the vaccine process a year ago, we had troubles encouraging our partners to increase the number of doses available to Santa Clara residents. Now there is no paucity of doses available. So it's pretty hard to explain why we're seeing low numbers in some of our partners. We have tried the nice, cajoling, concerning approach. I think we probably need to be more directive and penalty oriented. So we're looking with County Council at what our options are, and I'm certain that you will ask some questions about that as soon as I be quiet.
You know me well after 9 years, Dr. Smith, because I am in fact going to turn to Mr. Press from our County Council's office and ask, understanding that the decision rests with the public health officer, the public health director, that would be Dr. Cody, and is not a decision of our board. What legal tools are available should the public health director feel the need to use them to compel a stepped up effort by the Palo Alto Medical Foundation? Because we don't have a lot of time here.
Yeah, I would say that this is something that certainly that this could be reachable by a health officer order. There are some other reasons why contractual enforcement might not be the best pathway, and we can prepare for you an off-agenda report to explain that. You probably would see why in the memo why it would have to be a confidential off-agenda. But I can't see at this point why a health officer order might not be possible.
Okay. Mr. Press, you hinted, I thought, quite broadly and effectively that I might not want to lay out the legal possibilities and or prohibitions here in an open public meeting. I got the hint, and I will let it go, except to say that if there is no other solution, and I certainly hope there is, but if there's no other solution, then a flat out order to provide the vaccine, the boosters that we're speaking of, I, for one, want to make sure that it is a usable tool and one that is considered if necessary, because you know, I have seen the charts, and thank you, Dr. Smith, showing that, you know, we're at 40% plus in North County, and that's probably among the best, if not the best, on boosters as compared or contrasted with other parts of the county. But again, I'm looking at today's PowerPoint, the latest assessment by Public Health that says quite bluntly, a booster is needed for everyone who is eligible and urgent need for boosters. And I'm looking at that, tragic milestone of 800,000 deaths, and I'm reading about the growing concern about Omicron, and I'm saying, why on earth are we not getting the level of delivery? And if I guess the last question I would ask, and then I will let it go, and I'll look, Mr. Press, for that confidential off-agenda memo, is are we quite confident that the Sutter Palo Alto Medical Foundation numbers are what they are being presented as? I know, Dr. Cody, you referenced the fact that they are from a state database, but I just want to make sure that, if we're going to focus our attention, it's focused fairly and in the right direction.
Well,
I believe
I'll defer.
the numbers are correct. Yeah,
All right.
I believe they're correct. Yeah.
Dr. Smith, do we know, and again, I'm not asking for it right now, but before the end of the week would be great, how many people, what percentage of Santa Clara County residents get their health care from PAMF as their primary provider? And then how many people and what percentage of the boosters that have been given have come from PAMF? Are those knowable things?
Those are knowable things, yes. We don't have them at the tip of our tongue right now, but we can certainly get you an off-agenda memo with that information. Yes.
And do you think that's gettable by the end of the week? Because time is of the essence on this. And I just think to the point that Dr. Cody made earlier about, patients need to speak up. If X percentage of the population is covered by PAMF, but only, a tenth of that number or a quarter of that number or a third of that number is a percentage, I should say, is getting the booster from PAMF, then that's a knowable thing, and people can be asked to justify those numbers or not.
Yes, I think we can get you some information by the end of the week, realizing that they're dynamic numbers. People change, but close ballpark is.
All right.
We'll do it.
All right, thank you. Let me check with the clerk. Thank you all. And again, this is in part about making sure that folks who should be served by PAMF are served by PAMF, and that we get those numbers up as high and as fast as we possibly can. But it is also about the fact that in areas where there are not healthcare providers, everything that our county is obliged to do for folks who could and should be provided a booster by their regular healthcare provider gets diminished, reduced, compromised because of the need to step in and fill the void. Dr. Smith, is that music to your ears? Just so you know I got that message.
Yes, music to my ears.
All right. Just wanted you to know I understood the systemic implications as well. All right, then let me just check with the clerk and see if we have any speakers on this issue.
I do have one.
Let's go ahead and give that speaker 2 minutes, please.
Our first speaker is Paul Soto, followed by Mike Rogers. Paul Soto, you'll have 2 minutes to speak. Please go ahead. Paul, can you unmute yourself? We'll come back to Paul. Our first speaker is Mike Rogers. Please accept the unmute. You'll have 2 minutes to speak. The timer will start when you begin speaking.
Hi, good afternoon, everyone. Quick question or input on the COVID data itself. I was actually looking through the data reports on the county website today, looking for a couple of things with respect to geographic and ethnic breakouts, but also I was trying to figure out what level of breakthrough cases we had, which is probably primary in the county. data that shows we have, which presumably people testing positive of unvaccinated versus vaccinated, but there's no denominator to those numbers. No vaccinated people being tested, vaccinated people are being tested, which would be useful in understanding what degree of breakthrough cases are actually occurring with Delta. Just again, looking at the risks of Omicron, et cetera, trying to understand breakthrough case differences between the two. That's really my only comment. I did just other peripheral data is, although the hospitals aren't showing it, there seems to be a lot more flu and colds going around in my extended families than I've seen the last year or so. But I don't know if the data shows whether that's influenza or just other cold viruses. But that's just peripheral data, apparent. And thanks for your time.
All right.
I have two more hands up. Our next speaker is Urvish Kumar Mehta. I've unmuted you. Please accept the unmute. You'll have 2 minutes to speak.
Thank you very much to the Board of Supervisors regarding to the COVID-19 situation. I think what becomes more important in terms of a data is the announcement. As with the current ongoing situation in COVID-19, it's vital that the County of Santa Clara continue to update the portal with the frequency of the patients that is being admitted versus the number of patients being cured versus the new cases that is being added as per the city by city, that how many number of people are being vaccinated, and also along with that, it is important that what are the new cases with the Omicron they are coming up with, and if there are any foreigners or if there is any demographic data that something can be added, that would be helpful as well. However, one more thing is what becomes more important in terms of a COVID-19 situation is that with the federal government, Dr. Fauci, who has recently been invited to a town hall meeting conversation with a congressman within District 18 and District 17, which is part of County of Santa Clara, it becomes important that County of Santa Clara continues to be updated with what are the recommendations from the federal government in terms of a COVID-19 situation to put into a place, as well as to increase the capacity in terms of a scheduling and in scheduling for the senior care, where actually the booster shots are required, even though the seniors are vaccinated, and though if there is any drive through that is required to be scheduled along with specific facility, the pulp sites as well. Thank you very much.
And we'll try Paul Soto one more time. Paul, if you're there, go ahead.
Yes, I am. Thank you. Thank you for circling back to me. Paul Soto from the Horseshoe. Thank you for the questions that you asked, Supervisor Lee. You accurately, in my assessment, you accurately nullified the definition of fully vaccinated. That is there's nothing, there's no substance to it to support that. And so with that being the case, I think that needs to be articulated. You're dealing with just a regular average person that is just going by word of mouth or what they hear on the news. And so I think having the authority of the office by which Dr. Cody occupies, that it should come from that level, and that this needs to be articulated clearly, because I hate to think that, like, how many lives have to be lost? I mean, really the question becomes, Dr. Cody, is how many lives are you comfortable losing before you feel compelled to move? Now, you had moved expeditiously with respect to when COVID first hit, and that was a hard decision to make because you had no reference point, and you were going by your instinct, who you were consulting, and I would ask that if you would trust that again, because to err on the side of caution at the expense of business. Honestly, I don't care about businesses. I don't care about the flow of commerce. I don't care about whether or not a small business, has to take out another loan or something. Don't worry, Scott Neese and all these downtown associations, they'll be fine. They will be fine. They're going to complain, but all we're talking about is money being exchanged. That's it. That's it. And that doesn't rule my world. That doesn't run my world. And so I'd really like to know how many lives lost are you comfortable with? Thank you.
That concludes our requests.
All right, thank you. Supervisor Lee, we, I think, have covered this topic fully for the day. We'll thank the team again. A simple motion to receive the report, provide direction to provide the data requested in connection with Sutter/PAMF by end of week, as well as confidential data from our county council. And if you could make that motion, I will second it. And then we'll go to Dr. Smith, who I see has his hand up, and forgive me for just noticing Dr. Smith. Supervisor Lee, can I get a motion though, just so we've got it on the floor?
Please. Thank you.
Thank you. And I will second. And Dr. Smith, final word?
I just thought that since we were encouraging people about vaccination, that it might be good to reemphasize that they can go to our website, sccfreevax.org. You get a few questions and you get to some page like this, depending upon what location you want to be at, and you can schedule. You see the county has a number of spots available at various locations. I just want to reemphasize to people that there is a way to get their vaccination now, and everybody should get boosted.
Thank you so much. All right, call the roll, Madam Clerk.
Vice Chairperson Lee.
Aye.
Chairperson Simidian.
Aye. All right, motion carries unanimously, and thank you again. That takes us to item number 7. And this is the item that we have been working on since the item came back to us in June. Let me go to Mr. Lorenz for and his team for an initial report. This is the Adult and Adolescent Sexual Assault Forensic Exam SAFE program report. Mr. Lorenz, who is it going to present from your team, if I may ask?
Thank you, Supervisor. Kim Walker, the Program Director.
All right. Thank you. And Ms. Walker, we'll go to you.
Good afternoon, Vice Chairperson Lee and Supervisor Simidian. My name is Kim Walker, and I'm here today to give you an update on what we've been doing since our last report in November. In the interval the last month, we've been focused primarily on hiring, on operations, and on community outreach. Our response to the locations both at Stanford Emergency Department and Valley Medical Center have continued. We've been quite busy. We did 165 cases in October and November, and we've already done 40 this month, halfway through the month. So this last quarter has been particularly busy for our program. We also are working continually in preparation of opening up our South County location at St. Louis Hospital, which will be at the beginning of the year. And you have our report with the details in it, but we're happy to answer any questions that you have regarding the work that's been done.
Thank you. Folks, forgive me, tech difficulties plague us, but I've got my screen turned back on again. And if we have bandwidth problems, I'll just go back to audio only. Ms. Walker, I know you know, and certainly Supervisor Lee knows, but for those who may be joining us for the first time, I think it is perhaps worth recapping, since we're hoping to bring some closure to this conversation today. Recapping that last June, we heard from folks in the community, their concerns about what the experience was at the pilot program that was operating at Stanford Hospital, and in June made the decision that we would task the Valley Medical Center team with trying to make improvements there in cooperation and collaboration with the folks at Stanford, give us monthly reports, and refer the matter to both our Women's Commission and the system. We have now received that audit, so I should mention that just as a matter of record. It is before us today, and Mr. Lorenz and Ms. Walker, I just want to confirm there were 12 recommendations there, and I believe you have agreed to and accepted all. And did you hear all that? I've just taken the video off because we're having the same problem.
I believe you asked if we agree with the recommendations.
And agree, accept, and either have implemented or are in the process of implementing all 12.
Yes, agree, and we are in the process of implementing all 12.
All right, thank you. And then we also asked that the issue be heard by our Women's Commission. And Ms. Walker, I know you were slated to meet with them, I think sometime earlier this week or last week. Did that meeting take place, and anything to report from that you'd like to share at this time?
Yes, we presented on Monday night, and we had several questions from the group. The commission had information additionally they had asked for, but it went really well, and they are now more aware of our program and all of the issues surrounding the response locations and the level of service provided at each.
And they had access to the audit as well, yes?
I understand that some had read it and they know where to access it if they didn't already.
Okay. And then I just want to make sure to summarize the situation at the Stanford site, understanding that this exercise allowed us, gave us the opportunity to, which I thought was very helpful, to look at the complete program, you know, not just countywide, but also in connection with our neighboring counties, Santa Cruz and San Benito counties. But as to the Stanford location, we are still on track to have a dedicated, not just designated facility there. And we're still on track for that work to be completed, barring any issues with OSHPD, in 2022. Am I correct in my understanding?
Yes, I would clarify though that we do currently have a dedicated space. It is considered an interim dedicated space because there is additional construction to make sure there's a shower located inside of that space. But right now, as of October 24th, we have been in that dedicated space. So the only thing we have to leave for is the shower.
A very important clarification, because that was among the highest of concerns. I know you have been working to try and address issues around what I'll call the workflow and the survivor experience when someone is presenting themselves at the emergency department. What's the current status of those efforts? What would you tell us you feel has been accomplished and what remains to be accomplished?
We have done a number of trainings for both Valley Medical Center and Stanford Emergency Department. We've also done, even as recent as today, trainings for Vaden and the Student Health Center on campus, at Stanford campus, and then their resident RAs there as well. So we are making sure that we can get current understanding of how to get and access exams at all locations, and then getting their feedback so we can additionally enhance what we're providing and how we can access students and community members better.
All right. Ms. Walker, I hope you'll bear with me here. I have half a dozen items because this will likely be the last of our monthly conversations. I am going to ask that we hear back from you twice a year on these issues, just to make sure that we stay fully aware and on top of the work that needs to be done. But I just wanted to confirm that everyone in the Stanford Safe workflow is trained not to ask survivors for their story multiple times, so that survivors don't have to share sensitive information in a public place. Is that training in place now?
Yes, that's been part of our training throughout the process, is to make sure we limit just to what is medically necessary for questioning to take care of the patient outside of what we do.
Thank you. And I want to encourage you and your team to continue your outreach efforts and continue looking into ways that survivors can disclose the necessary information as discreetly as possible once they arrive at the ED. I don't think I need to encourage you. I think you're already doing that, but I just want to make sure that the plan is for that to be a continued area of effort and emphasis. Yes?
Yes.
Thanks. And I know that there's been some discussion about what is sometimes referred to as the Zen rooms at Stanford being used for patients as a place to wait in if they're not able to be taken into the triage or medical exam area immediately. Do you know if that's something that has been done, is being done, can be done in the future?
There are a couple of rooms, but the room that has been dedicated for us in the triage area, I understand will continue to be dedicated throughout the construction process.
Well, thank you. You anticipated my next question. So it is the understanding with the hospital that the room that has been dedicated will continue to be dedicated until we get the dedicated space fully functional over the course of the coming year. Yeah.
That's my understanding. I know that Allison Kerr is also here if that needs to be confirmed through Stanford.
Ms. Kerr, if we can pull you in just briefly, and I don't want to prolong the conversation unnecessarily, but is that your understanding and commitment as well?
Yes, it is, sir. With the caveat that if we get rapid amounts of volume and surge in our emergency room, we are going to have to continue to we may need to use that in rare instances when we are overwhelmed with patients. But it is our priority to secure that room for that intended use for triage. So we expect to have it dedicated for that until construction is complete, with the caveat unless we got overwhelmed with volume, which so far we've been able to secure it. But I just with so much unknown coming up, I just want to make sure people know that we will always do our very best to secure that with that exception.
Thank you for that. Going back to you, Ms. Walker, I know you all take very seriously the value of feedback from survivors, but one of the challenges, of course, is trying to be sensitive to the survivors and their experience and not re-traumatize folks. Some of the survivor input is not terribly current, somewhat dated. Your thoughts first about whether or not that survivor data and input can be incorporated in what I'll call continuous improvement in our programs and services. And then also, is there a way to appropriately and respectfully and sensitively pick up any more recent input that would help inform your efforts?
Well, first, we work closely with the advocacy groups, and they are constantly working with the patients even after they see us. So their feedback is really helpful, the survivor feedback through them. But then also working with Children's Senior Family Committee, we are continuing the survivor survey. We have to report back in January on that. That is an ongoing workflow with that committee that we can share data as it comes in for survivor experience and feedback with this committee.
Thank you. Last question, and then I'll go to Supervisor Lee, and then we'll hear from the public. I am anticipating that at this point, in addition to saying thank you to everybody who's made this effort over the last several months, that we would ask you to come back twice a year just for follow-up reports in the coming year, presumably mid-year and end of year. Does that seem like a sensible schedule to you, and is that something you can accommodate?
Yes to both.
All right. Supervisor Lee, let me turn it over to you, see if you have additional comments or questions, and then we'll ask the clerk if we have folks who would like to speak. And if you are listening in, folks, and would like to speak, please go ahead and sign up now, raise your hand so that we can assess how many speakers we do or don't have today. Go ahead, Supervisor Lee.
Thank you, Chair Simitian. The report mentioned that there was an increase in the non-fatal intimate partner strangulation cases in the county. Do we have more specific information on what the increase was compared to last year?
I don't have that. I can provide that to you, but I don't have that data in this report.
All right. Now, in terms of the exams, the report stated there are 601 exams conducted so far in 2021. And of course, we still have a few weeks left in this year, and that there were 477 exams performed in 2019. Is this a result of a significant increase of sexual assault because of the students returning to college campuses? And we're just trying to find out if the rationale of the increase, or is it the fact that we have been able to make these exams more accessible?
I think it's multifactorial, but also this does incorporate an expansion of the strangulation services. So I think as more law enforcement agencies come on board, that we've moved from a pilot to a service there as well. Plus, I think that people are gathering, so there is more interaction and unfortunately assault, and there's more reporting, which is a good thing.
Right. Okay. As for the services for those who are surviving from this, for these clients, what is the situation for those who might not have insurance, and is any type of delay potentially because of they not having the insurance coverage when it comes to like counseling or therapy options?
That often is handled after they see us. We see the patient in the acute period, so the exam and support services are taken care of through the hospital and then through the rape crisis centers or the domestic violence center. So they're funded for exactly those services, and then they augment our work. And
so in that case, is insurance even an issue, or this is something that they'll automatically get the services and we deal with those insurance status later on?
For the sexual assault medical forensic exams, by law, we can't charge for any of what we do.
Right.
But if there is medical need, which there can often be with strangulation, that the patients will go to the emergency department, and we work very closely with victims of crime, victim services unit, the advocates groups, and then making sure that if there is any potential charge to the patient, that we can augment that with victim services and victim funds.
Okay. All right. On the different recommendations on 2.1, is it possible to speed up this timeline, right, and report on these requested items to the board by March 22 instead of June 22 as stated? Because we know that the need is there since the safe services are increasing, and I'm mindful of how long it takes for us to hire staff if it's determined that an increase in staffing level is necessary.
So forgive me, the question is whether or not we can report back on how the staffing is going?
Yeah, of how we could get this staffing coming back sooner than later, so that if we do know that sooner, then we could immediately get people hired on board, since it does take a while to get folks through ESA and getting hired, right?
Correct. We're actually working on that right now. I just had a list submitted to, actually 2 lists submitted to me yesterday. So we're working on that very hard right now.
Okay, so these items probably could be reported back sooner than the June 22 as stated. Yeah, okay, great, thank you. On recommendation 4.1, can we get some confirmation that these website information is also being available in other languages other than English based on the county policy?
Yes, we're working on that. And we're hoping that we can get a QR code that will allow it to be in all languages. So whatever the patient chooses, we can have that available to them.
Great. And the last question I have regarding is 5.3 recommendation regarding the extra help position. Do you know how many hours are we anticipating to fulfill this position?
I don't. This is something that would be incredibly helpful for the SARC committee and also Office of Gender-Based Violence through the CSFC committee. In addition to what they could help with the SARC committee and kind of the administrative work with that, the CSFC, the database that is being built, so all of our forms that we use to report these exams would aggregate into quite a large amount of data that
Right.
can be used as a database and dashboarding that they would be very helpful with for the Office of Gender-Based Violence to keep updated and available to you.
Right. So I just wanted to make sure that we do have budgeted enough, because obviously this is going to be a lot of work for this new position. Right. Okay. And that's all the questions I have. Thank you very much.
Thank you very much, Supervisor Lee. And again, I apologize to all. My office is telling me that we're really having some challenges with our connections today. And so I know that makes for a difficult meeting. Let me go to the clerk and ask, do we have speakers on this issue? And if so, how many have raised their hands?
I have currently one hand raised.
Well, then let's go ahead and give that person up to 2 minutes and see if there are others who follow.
Thank you. Our first speaker is Michelle Dauber. I've unmuted you. You'll have 2 minutes to speak. Timer will start when you begin speaking.
My name is Michelle Dauber. I'm a professor at Stanford. First, I'm in agreement with the audit recommendation that Stanford be contractually obligated and accountable to provide dedicated facilities that it has agreed to provide, including during construction. During my tour of the facility in August, multiple Stanford officers assured myself and Supervisor Chavez, without any caveat, that the Zen room would remain dedicated until the completion of its construction. That commitment should be included in the contract. And I have to say, as an aside, Allison, this is why trust between survivors and Stanford is so damaged, because when we met, you didn't provide any caveat, and today is the first I'm hearing of it. Second, regarding training, during that tour, I and my PhD student both felt that the most likely failure point in the workflow is the reception and triage when a victim may mistakenly be sent to wait in the general waiting room. We were assured that additional training will be provided. We feel that that training should also be contractually mandated due to the same trust issues that I just mentioned. And finally, we remain quite concerned that survivors have to interact with more people at Stanford compared to VMC prior to being placed into the private waiting room. I hope that the supervisors can persuade Stanford to try to reduce the number of people that survivors have to interact with at Stanford. And since I still have 30 seconds, I just want to say that I was absolutely prepared today to praise the progress until I heard Vice President Kerr insert a caveat regarding the Zen room availability and dedication, because that was the subject of a lot of conversation during my visit. And I just can't emphasize enough that this is why trust is damaged, and this is why you have had to come here every month for the last 6 months, because we don't trust you.
Our next speaker is Urvish Kumar Mehta. I've unmuted you. You'll have 2 minutes to speak. Please go ahead.
Thank you very much to the Board of Supervisors again. I want to mention about the Santa Clara Valley Medical Center and the other facilities about within the County of Santa Clara. There's recently on December 15th only, there was a biomedical device, a global manufacturer event within the County of Santa Clara, where Google Health, Intel, J&J, Stryker, and the peer therapeutics among global manufacturers were attended in order to provide the exhibition and the broad information about that, how the smart devices and the biomedical devices are changing the health in the advancement, and especially in the MedTech Center. With respect to current ongoing situation within the COVID-19, they are also providing the set of a different standard for the PPEs to be established, not just in terms of a mask, but also providing the advanced set of devices where any therapeutical advances and the medication and the therapy that is required for the patients to be cured, these devices are to be procured by the specific facilities within the County of Santa Clara. Also, they are providing the flash report cards as well, which is allowing those facilities to acquire those devices based upon the requirement. Say, for example, if it happens to be oxygen cylinders for providing the oxygen to the patients, then they are providing the 25%, hoping directly manufactured devices value to with the executive level title. So certainly to look up to those devices, from this institution to take over. Thank you very much.
That concludes our requests.
Thank you very much. Ms. Walker, I can see you present on my screen, so I know you heard the comments from our speakers. I do want to reiterate and ask you to reiterate the fact that you will continue to stay engaged on these training and education issues and workflow issues in an effort to see if we can't find even more improvement in the process. Yes?
Of course, yes.
Yeah, and I think, and Ms. Walker, forgive me, I know you know this better than any of the rest of us, but I do think it's important that we understand that this is a continuing effort, that personnel changes, community members change, police departments change, certainly students move on and new students arrive. So, regrettably, the work is never done. And even more regrettably, the fact that the numbers are up mean that there's going to be an even greater demand. So a continuing effort, and that's why I'm certain that we'll need to keep pulling you in at least a couple times a year, and with even earlier updates to Supervisor Lee's requests as necessary. All right, Supervisor Lee, other than say thank you to all who have made such progress, including the now use of a dedicated space at Stanford for the SAFE program, and thanks as well to advocates who raised these issues with us last spring or early summer, because that was essential to the progress we've made since. Let me see if I can get a motion from you to simply receive the report and direct staff to come back to us at least twice next year.
Right, so moved.
I will second, and we will call the roll.
Vice Chairperson Lee.
Aye.
Chairperson Simonian.
Aye. All right, motion carries unanimously, and again, with our thanks. That takes us to the next item, and that next item is item number 8. And forgive me, colleagues, before we call out that item, I just want to check to make sure that we're good to go, and I believe we are. The item number 8, of course, is the CalAIM item. And if I overlooked anyone on the last item, my apologies. My staff is indicating that there may have been a hand raised, and if I missed it, I apologize. Just didn't show up on my screen. Item number 8, Mr. Santiago, CalAIM and managed care.
Yes, and good afternoon, Mr. Chair Simonian and Supervisor Lee. We submitted a written report, and I know Ms. Christine Tomcallis has a PowerPoint presentation. So I'll begin by making some few brief remarks in case refresh our memories. This is a report, a continuation of the report that we made over the last 2 months, keeping you up to date as our Health Policy Committee in terms of CalAIM and the transitions. We indicate in our update that since last month, we had submitted transition plans to both Medi-Cal managed care plans here. As you know, we have a 2-plan model, one private, Anthem Blue Cross, and the other one public, Santa Clara Family Health Plan. In those transition plans, we were very specific about the programs, the initiatives, and the staffing and the dollar amounts necessary to continue to not only safeguard the gains that we made as part of the whole person care and other initiatives, but also to advance our integration. Subsequent to that, we have received contract agreements, proposed agreements from both plans. In that particular case, we're having county council review the specifics in terms of the legal requirements. And then, of course, we're doing our due diligence and the analysis, working closely with BHP and Laura Rosas and her team to ensure that, in fact, we can do those services and requirements given the proposed rates. The other piece that's important that we provided in the written report, it is our interest to continue to make advances in terms of not just the projects, but also the initiative. is so core to our transformation of having integrated care, more comprehensive care for all the populations in our community, but more specifically the vulnerable. We have links to some of the videos that our staff have produced that show the value of these initiatives. We've also had a stakeholder process where more than 200 people participated. We've gotten very positive feedback in terms of the value of these services. And at this point in time, we don't have plans to reduce services. In fact, we are developing contingency plans as part of the mid-year so that in case there's any gaps, that we continue to address those gaps and in fact provide the care that's necessary for those populations. So that concludes my brief remarks. And then if there's any questions or you want to go directly to the PowerPoint by FHB, we can do that as well.
I think what I'd like to do is take just technical questions now. I have one quick one, which is why I'd like to take just technical questions now, then go to the PowerPoint and then engage in a more fulsome conversation. Let me ask Supervisor Lee, however, if he has any just technical or clarifying questions before I ask my own.
Yeah, thank you, Chair Siminian. There's a few questions I was going to ask. So let me start with this. So the report has stated that the transition plans have been submitted to both MCPs to address gaps and safeguard the gains made under the current waiver. With the transition to CalAIM, it is important to not lose ground in promoting health and well-being of the communities we serve, unquote. Renee, can you please explain the gains that's supposedly made under the current waiver and the context behind not wanting to lose ground in promoting the health and well-being communities we serve?
Yes, some of the gains that we've reported in the past, for example, is as part of our whole person care initiative, where we enrolled more than 7,000 clients here locally. We're able to have the flexibility to provide a variety of different service and interventions. Some of them were peer-based, for example, for people that were suffering from substance abuse, as well as clinical conditions. Some of the populations where we're having strictly multiple chronic medical conditions, along with mental health conditions. So we had a lot more flexibility in terms of designing services and interventions based on the needs of the individuals. I think as the state moves to standardize this under an enhanced care management, not just for us, but across the whole state. And if you remember, there's counties that don't have a whole person care initiative like we did. So they're trying to standardize it to a level that would have minimum requirements that are still negotiated with the federal government. We don't want to lose any potential gains that we have, services that we have, strategies on the ground. So it's very important for us, obviously, to get the support necessary from Medi-Cal managed care plans, but then also to make sure that there's no gaps going forward, as you indicated.
Okay, thank you, Renee. I recognize the seven. Oh, this is a question more for the Santa Clara Family Health Plan. I recognize that the 7 populations of focus highlighted in the presentation, and also the note at the bottom of slide 9, talking about not all whole person care enrollees may qualify for the transition to the enhanced care management. Is your health plan concerned about any populations that may fall through the cracks in this transition to CalAIM, such as people with chronic conditions? And if there are any, then what is the plan to serve these populations?
Yes, good to see you, Supervisor Lee. We are concerned, and I think that some of the individuals who fall through the cracks and do not transition over to ECM, some of them will be qualified for complex case management. And so there is another opportunity to provide some of those services under our existing care management services.
Okay. Okay, and at this point, I think that's all question I have for now. Thank you.
Thank you, Supervisor Lee, and thank you for the musical accompaniment. And the only question I have, and forgive me, it's just a lack of knowledge on my part. when we talk about, and this either Ms. Tomcallis or Mr. Santiago, either when we talk about transitioning from HHP and WPC, Health Homes Program and Whole Person Care, to the new enhanced care management and the community supports, is that forgive me, I'm struggling to frame the question. Is it a one for one, meaning one program replaces the other, and then the second program replaces the second program, and essentially we've got slightly different programs with new names? Or is it sort of those two things are replacing those two things? Did you understand the question, Mr. Santiago? Let's start with you.
Yes, and not exactly, Chair Sabidian. It doesn't really overlap 100%. So you're right in the sense that there's these initiatives, there's these programs. Health Homes, for example, is part of ACA. Whole Person Care was a negotiated agreement as part of the 1115 waiver just with the state of California. So it's not a perfect fit, one for the other. That's why we're doing our due diligence to make sure, because as a provider, as a county, quite frankly, you mentioned the healthcare system. At the end of the day, we assume the risk for these populations. So if the healthcare system doesn't do what it needs to do in terms of care management, coordination, provision of services, prevention strategies, some of these clients end up in our jails, they end up in our emergency psychiatric unit, they end up in our hospitals. So it's incumbent upon us as a county, as well as a health system, that we try to fit as much of it as possible, working obviously with the Medi-Cal managed care plans, and to the degree there's any gaps in the risk, that we still ensure the continuity of care for those populations.
Okay, and let me try asking the same question a slightly different way. So, Mr. Santiago, in my experience, we've spent a lot of time the last couple of years talking about whole person care, not so much candidly about Health Homes Program. If somebody said, wait a minute, I understand whole person care is going away on January 1st, what's replacing it, if anything? Is the best answer, well, it's mostly going to be replaced by community supports, or is the best answer is mostly going to be replaced by enhanced care management, or it's mostly going to be replaced by those two things together, or it's mostly going to be replaced by those two things together plus some other supplemental programs that we will use to cobble together a complete replacement for whole person care? How is that for a jumbled collection of options?
Well, it's the fourth option, the way of our perspective. Some of it is going to be done with community support. Some of it is going to be done with enhanced care management. Some of it is going to be done by a combination of those two. And then, of course, the supplemental things that we're going to have to do.
Okay. Ms. Tomcallis, let me ask you to lean in, and I will let you get to the presentation, I promise. But is that sort of consistent with your expectation as well?
Correct. I think it is a combination of both enhanced care management and community supports under CalAIM that primarily will be replacing the whole person care program. And as Renee mentioned, there will be some supplemental efforts needed. Some of that might be through existing Medi-Cal benefits, as I was mentioning, the complex case management, and some of it may be continued services by the county health system that doesn't really fall under any of the Medi-Cal benefits or programs.
All right, I do have one more question, but I'm going to hold off and ask you to go ahead and provide your presentation now, and then I will pop in with my question.
Thank you so much, Chair Simidian and Vice Chair Lee. I'm Christine Tomcallis, CEO of Santa Clara Family Health Plan, and I'm pleased to present to you our plans for launching enhanced care management and community supports under the state's CalAIM Medi-Cal Reform Initiative. We have about 15 slides here, and I will be happy to expedite the conversation and focus my remarks on just a few of the slides. So if we can advance directly to slide 5, this addresses enhanced care management, also known as ECM. And It is a new Medi-Cal benefit that we must offer to all members who meet the ECM target population descriptions, not just the members that are currently served under the whole person care and health homes programs. We are also mandated to contract with existing local providers that are currently providing services to both the health homes program and whole person care enrollees, with very few exceptions. And that includes as well a contract with the county for the county behavioral health system for members and behavioral health services for behavioral health needs and children in the child welfare system. Through ECM, we must provide services that are high touch, that are on the ground and face-to-face by experienced providers. As we move on to slide 7, there are 7 populations of focus for ECM, and 3 of them are listed here. We have the homeless adults and families, the high utilizer adults, as well as adults with behavioral health needs. And the other 4 are on the next page. I won't read the complex eligibility criteria for each, but it is included if you are interested. So the next 4 we have on this page are the members transitioning from incarceration, individuals at risk of institutionalization, nursing facility residents transitioning to the community, as well as children and youth. You'll note on the next slide that not all populations become eligible at the same time, but rather phase in over an 18-month period. However, members that are currently receiving services through either the health homes program or whole person care will transition to ECM in January of 2022, regardless of their population of focus. Okay, if we can move on to slide number 10. These are the organizations that will be providing ECM services for our members starting in January. And as I mentioned earlier, ECM is intended to replace health homes and whole person care. And so to comply with state guidance, as well as to provide continuity for both the health homes and the whole person care members transitioning into ECM, our network consists of existing health homes and whole person care providers. As we move on to slide 12, as we do, I'm not sure. Okay, I'm sorry, slide 11. Thank you. The intent of community supports is to invest in alternative services that are not Medi-Cal benefits and that may illustrate an impact on have a decrease in enrolled members' use of hospital and nursing facility stays, delays in discharges, and ED use. The Department of Healthcare Services has stated that they intend to start asking plans to submit impact data on these services in 2023 with the intent to convert them to Medi-Cal benefits sometime in the next few years. And now as we get to slide 12, it's the full list of the community support services that DHCS is allowing plans to offer, as well as our planned phasing to implement all 14 over the next 18 months. And DHCS has also issued specific eligibility criteria for each of these services. And again, I won't go into the details, but would be happy to answer any questions if you have them. As we move on to slide number 13, these are the organizations that will be providing community supports to our members starting in January. And again, similar to the ECM network, most of these are existing health homes or whole person care providers, or both. So thank you for the opportunity to provide an overview, and we're happy to entertain questions.
Thank you very much. The date that struck me, of course, was January 1st, 2022, since that is just a couple of weeks away. Mr. Santiago, you know, we have a lot of programs and services. We have a multiplicity of dates. We have different organizations that we work with. Who needs to contract with whom to effectuate this transition from whole person care and the waiver more broadly? Who needs to contract with whom to effectuate the transition from, you know, the waiver provisions and whole person care to the CalAIM system that we're going to start engaging on January 1st.
Yes, and it sounds like a simple answer, but it's a little bit complicated. If you could just bear with me. The state is requiring the Medi-Cal managed care plans, in this case, Anthem Blue Cross and Family Health Plan, to contract with a network of providers to provide enhanced care management and community supports. At the same time, we are hearing from the state of California as a public hospital system that's been doing the Whole Person Care Project, that we must be vigilant about not only negotiating with the Medi-Cal managed care plans, but also to advance the integration and the comprehensiveness in terms of care and service. We have taken a position that this is something that I've obviously worked very closely with Dr. Smith to make sure that we contract as one county, because we know that as a county, we can provide more supports, we can provide more cost-effective care, more comprehensively and integrated, to take care of the needs, whatever they might arise, because they might show up, quite honestly, in terms of failing to do those things in our jails or in more expensive care systems. So that's essentially my answer, which is we're taking the position right now with Family Health Plan that they need to contract with us as one county.
Ms. Tomcallis, what's your take on that circumstance?
We need to contract with the county, and I think that there is some discretion in terms of how that's done. And if I may ask Tyler to speak further toward this.
Please do. And we'll have Mr. Haskell tell us who he is, just for the record, please.
Hello, I'm Tyler Haskell. I'm the Interim Compliance Officer and Government Relations Director at Santa Clara Family Health Plan. And specifically, the CalAIM proposal requires Medi-Cal managed care plans to contract with existing whole person care and health homes program providers. And there's some specific guidance in addition to the proposal that we're following to do that.
So thank you. So let me ask Mr. Santiago, and if I need to pull Dr. Smith in, please feel free to lean in, Dr. Smith. Are we going to get these things done in the next 2 weeks and 2 days? Since I noticed the calendar is not our friend.
We're hopeful because as a county, as you know, we're one single entity. We only have one county IRS number, and so I think we're hopeful that FHP will recognize that it's actually to their advantage and to the advantage of the populations to contract with one county and be able to leverage other services and programs that we have.
Yeah, I sense a little underlying tension here, and if so, that's fine, gang. Ms. Tomcallis, is this an issue at one county versus 2 or 3 different offices within our county? Where does this stand?
I don't know what Renee is referring to in the details, right? So I think that's where the challenges may lie. I'm fine if we include all of the components in one contract with the county. We do need to have contracts with OSH, the Office of Supportive Housing. We need a contract with the Behavioral Health Department. We need, a contract with others in the county. So if that can all be accomplished under one contract, that's fine. I don't have any concerns about that, but I don't know if there are other things being referred to in the details that may or may not be okay.
All right. Dr. Smith, could I get you to weigh in on this one?
I again don't really think there's a problem. I think we will accomplish it on time. As a governmental entity, we are all one entity legally, so the departments don't exist separately, so the contract would be between the county and the family health plan, and so I don't think there'll be a problem. We're trying to coordinate that. The complexity does get a little bit more by recognizing that we do, through Valley Health Plan, take responsibility for a delegated population of Medi-Cal beneficiaries. And so there is separate responsibility that we have to those individuals. And that's separate from Family Health Plan's responsibility to the other beneficiaries that they don't delegate to us. But we're one county, we multifaceted. I don't see a problem getting a contract that does everything that's required.
All right. Well, Supervisor Lee, I'm going to ask you to lean in. This is a little unusual here, but what I think I'd like to do is just say I have really appreciated the opportunity in this meeting and in the last, and with the materials we've been given, to I don't think there are huge policy issues here, but it's clear to me that there are very big administrative and operations issues that you all have to wrestle to the ground. So I'm just going to say, Dr. Smith, my hope and expectation, underlining the word expectation, is that the county and the Family Health Plan will have a completed contract or contracts as necessary. I understand you're both going to tell me it takes two to tango, that, you know, each of you has to be reasonable and diligent and all of that, of course. But I'm just going to say my hope and expectation is that we're going to get to January 1st with signed contracts and a smooth operational handoff and transition. Supervisor Lee, if you wanted to lean in and say me too, I would appreciate it. If not, that's your choice as an independent supervisor.
Thank you, Chair Simitian. I definitely echo your concern. And my concern is that January 1st is not only around the corner, we've got a lot of holidays in between. So time is of the essence, and we are running out of it. I certainly don't want to have a bunch of lawyers going back and forth arguing a couple of points and have this delayed and starting a gap, and that's not a good way to start a new program. So I'm extremely concerned to make sure that we could get us on one contract for the county. I think that's great. Whatever the bottom line is, that we just want to make sure that there's no gaps, no services that's needed to be implemented before this start date. So I definitely support what my colleague Chair Simitian just mentioned. Thank you.
All right, thank you. Mr. Santiago and Ms. Tomcallis, I think we are at the point then where I can ask Supervisor Lee if he's got a motion to approve the recommended action, which is simply to receive the report. I would second it, and then we'd see if we had community comment. Supervisor Lee has made the motion. I will second it. Let's turn to the clerk and see if we have community comment.
I have one request to speak from the public.
Let's go ahead and give 2 minutes to that speaker, please.
Just a moment for the timer. Our first speaker will be Urvish Kumar Mehta. You'll have 2 minutes to speak. Timer will start when you begin speaking.
Thank you very much to Board of Supervisors, respective Chief Executive Officers of the county and the county officials as well. I wanted to mention about when any particular plans, whether that be an individual plan or whether that be a family plan or a Medicare plan that is being introduced. What becomes important for the plan is to introduce a model where most of the coverage be provided to the consumers and the patients, and as well as they be available in network and out network. And also from that perspective, what is being seen is the benefits, that how the patients are being benefited with the coverage that is being provided part of a health business. Now, what in terms of the medical, the insurance and the plan provider, what they see is the ratio of a claim cost to the premium revenue. So in terms of the better the medical cost ratios, MCRs, versus a margin versus the MVB, the better the plan would be. So I think it is important.
Urvish, we've lost your audio. Urvish, are you there?
I think we will just have to say thank you for the comment that we received, and Unless there's anything else either from Mr. Santiago or Ms. Tomcallis, I will call the roll. Mr. Santiago, are we good to go?
Yes, we're good to go.
All right, Ms. Tomcallis,
Good to go.
call the roll.
Vice Chairperson Lee,
Aye.
Chairperson Simidian.
Aye. Motion carries unanimously. Thank you both, and look forward to having a contract signing party with you on January the 1st, if not before. All right.
Thank you.
Thank you. And that takes us to item number 9. Item number 9 is the Alcove informational report. It is just that, Supervisor Lee, and mindful of the hour, I think what I will do is tell Mr. Rao, thank you for the report. It seems clear that progress is being made, but the one thing we could and should do is explore continued outreach to make sure that now that the systems are up and running, they are made known to folks who might benefit from using the system. And anything we can do to help in that regard, please let us know. Otherwise, I am prepared to ask for a motion to approve unless you have comments or questions, which I don't want to preclude. Supervisor Lee, your call.
Yeah, I do have a few questions.
Go to it.
Please, thank you. So our office has been told about some serious safety concerns over at Alcove, San Jose. And I would like to thank Renee and Sherry for the office agenda report yesterday, highlighting the types and extent of the safety issues, and have some follow-up questions. The final page of the office agenda report has a table detailing 7 items related to the Alcove Safety and Action Plan as of December the 3rd. It seems like the security person hired played a crucial role to ensure the safety of staff and youth visiting center, as well as being the first responder in any case of any type of activity. Does the presence of security person make staff and youth feel meaningfully safer? And what's the initial feedback from the staff and youth that you know about?
Sure. Thank you for your question, Supervisor Lee. We have several members of our team here, and Rachel Talamonte is our division director with our Children, Youth, and Family Division overseeing Alcove. Will be responding to some of your questions.
Thank you.
Rachel, I'll go ahead and turn it over to you.
Wonderful. Thank you. Good afternoon. The feedback from the staff has been very positive, as well as the youth. The security person is a designated individual, so we have the same person every day that really has been incorporated as part of the San Jose Alcove team. The youth are able to utilize the security to walk them to their cars or bus stops, also to call when they've arrived so that they can be escorted to the center if they'd like to do so, and we've had positive feedback. And the staff have also expressed that it's helpful to have this person, our security person, as a point person and walk them to their vehicles, as well as making sure they get to the garage in the evening and help close out the facility at the end of the evening. So thus far, it's been working quite well, and the feedback has been positive.
Okay, thank you. Now, the role about community partnerships in the Safety and Action Plan highlights San Jose Police Department, Abode, OSH, Second Street Studios, Property Management, and the Spartan Keys Neighborhood Association. Are these organizations participating in the community consortium at Alcove, San Jose?
So the San Jose Police Department captain for the area was just asked to join the community consortium, and he's agreed to do so. And the president of the Spartan Keys Neighborhood Association, she is already part of the community consortium. We have been meeting, in fact, today we met with the Office of Supportive Housing, First Community Housing, and we're working on meeting with Abode as well in terms of establishing the best route of communication and partnership, whether that's through the community consortium or through other means.
Yeah, just want to make sure that we extend the offer for them to participate, given the issues we have faced.
Yeah, absolutely.
Yeah, the next question, I guess, maybe for both Sherry and Renee. Assuming Alcove proves to be a successful program and given the frequency of these safety incidents at the Alcove San Jose, what's your thought about the long-term stay at 1144 2nd Street? Is that a good location? Do you think we might have to move it?
Supervisor Lee, we're really continuing to ensure that we are looking into all of the safety and security variables with respect to the current site. And we're exploring, all options for Alcove San Jose that continues to align with the model itself that has several requirements and the fidelity of the programming. for youth to have a space that is safe as a core component. So we're really taking into consideration all aspects of the programming, including the location.
Great, thank you. Well, if you need help on resources to provide additional safety, please don't be shy and let us know. We certainly want Alcove to be a very successful program. We know that. Certainly visit the Alcove Palo Alto site and look forward to do the same for San Jose in the near future. Thank you very much.
Thank you for your questions.
Thank you. And let me turn to Dr. Smith, who I see has his hand raised.
Yes, thank you, Mr. Chair and Vice Chair. I did want to let the committee know and the public know that we had a structural problem last night at the 2nd Street studio. We basically had a fire alarm that was activated, and the showers are sprayed down over the alcove location, so we have water damage and we're unable to operate for today. We have FAF working on it and the manager of the facility working on it. I expect it to be cleaned up rapidly. However, I'm sure you will hear of the disconnect of services caused by this event, and I want you to know we're on it. And then just to follow up with Sherry's response to Supervisor Lee about locations, we are looking at other locations as potential locations if we decide we need to move from the current 2nd Street site. But we're not at a place right now where we can say that there's a definite need or a definite new location, but we're going to keep all our options open as we move on.
Thank you, Dr. Smith. I will turn to see if we have speakers on this item. Madam Clerk?
There are currently no hands raised.
Thank you. Then I think what I'd do, Supervisor Lee, is ask for a motion to receive the report.
Yes, so moved. Before we discuss, I actually want to follow up question with Dr. Smith is, at this point, do you think Alcove will be open up maybe next couple of days? Number one. Number two is, was it a false alarm or was it actually a real fire that caused the fire alarm to go off?
Actually, probably Sherry can follow up more clearly about the plans. It was a 3rd story alarm that went off and activated the sprinkler system, which drained down into the 1st floor, 2nd and 1st floor. There's no fire risk to the building at this point. It's all water damage. And in terms of when it will be able to open again, Sherry, can you give us an idea?
Sure. Thank you for your question, Supervisor Lee. We are actively working with the building team to ensure that they can properly dry out the facility. The area that was primarily damaged through the water coming through the ceiling was the treatment rooms, unfortunately, and those are the areas where we provide the confidential counseling and therapy. And so there was water damage to the ceiling and to the walls. And so baseboards have been removed. They're trying to dry out the carpets, ensure that the walls are interiorly dry. And so we will know more Friday, but we do have a backup plan for those, youth that have current appointments, and we're able to provide those at an alternate location. So we're reaching out to all of the clients currently, and we will be keeping everyone updated with respect to when we can reopen the site. We're working as expeditiously as we can to get folks back in there.
Thank you, Sherry.
Thank you all. And I have a motion from Supervisor Lee. I will second it. And I will only add as part of my second that I think as we roll into the new year at the earliest opportunity, Mr. Rao, we ought to be talking both in terms of your department or agency and our board offices with how we can collaborate with Alcove to up the outreach effort. And I think, we want to be respectful of the fact that this is a youth-driven agenda, that since it serves young people and is a youth-driven agenda. That being said, I also think we can provide some support, some infrastructure, some collaboration, and it may just be as simple as some resources that the young clients are not even aware exist. So let's just make sure that come January, we put our heads together and figure out what we can all do to try and up our game on outreach. Clerk, please call the roll.
Supervisor.
Vice Chairperson Lee,
Aye.
Chairperson Simitian.
Aye. Motion carries unanimously. Thank you very much. That takes us to item number 10. And on item number 10, this is the clinic in Mountain View at 2500 California Street. We are simply being asked to receive the report. And I have just a couple of quick questions. Dr. Smith may need you to lean in and or Mr. Lorenz because they're not really construction questions as much as questions about sequencing in terms of our hiring. You know, I know there's been some reticence about moving to hire people until we knew we were going to have a facility that was actually open and ready for occupancy. On the other hand, I would hate to further delay things after the physical construction. Is there any way we can try and do those things in tandem? And I know that also requires some notion about what kind of services we're going to be providing there. Mr. Lorenz, Dr. Smith, either one of you have a thought?
Paul can probably give you the current status of the exact positions, but I can tell you that the board is going to see at its next meeting in January request for creation of a number of positions in health and hospital, and some of them will be specifically related to this clinic. But Paul, you can give an update in detailed way.
Yes, thank you, Dr. Smith and Chair Simitian. So the simple answer is that many of the positions that are going to be housed at and assigned at that clinic are common positions, such as pharmacists, nurses, the front office staff. And so those positions we are actively recruiting for because we do have vacancies. So our intention is to identify individuals that would be able to work at that location. So we are actively recruiting for these classifications as we speak. And as Dr. Smith has alluded to, any positions adjustments come January or thereabouts would further our efforts to ensure that the clinic is ready to be operational.
Thank you for that. That is a helpful clarification. Let me just ask a question, a follow-up question, Mr. Lorenz, and it's one that I candidly didn't see coming, and it applies not just to this facility, obviously, but what I've been told is that we sometimes encounter staff in a range of functions who, quote, don't want to have to go to the North County. And, you know, as the representative of that area, that always makes me, hurts my feelings. And then I wonder, what's that about? And then I say, why? And the answer is the commute, the drive. And part of that is because it's gotten to be such a high cost area that relatively few of our staff live there. Is this an issue?
Well, generally speaking, I would concur with you that the cost of living in that area is high, but it is high actually throughout the county of Santa Clara. I think in terms of our recruitment efforts, we do have to spend a little bit more time trying to identify individuals in the North County. So that is a recruitment process challenge that we have to work on. We do have staff that live in Palo Alto and in that area of the community. And I think as we establish services in the area, I think we will begin to identify people that want to work for the county and want to work for the healthcare system. So this is probably, in my mind, the first step in really rounding out our workforce of individuals that live in the North County.
All right.
Maybe I can jump in too. I've certainly heard similar concerns expressed anecdotally. I don't think it's a huge problem, but there are challenges with transfers of individuals who are already working for the county to different locations. Obviously, when we recruit, for trying to attract to transfer into that position, they have to apply, and if they're not interested in the commute, they won't. But when we're doing external recruitments, we include commitments to be working at the location that they're hired to, so that's less of a problem. I don't really think it's that big of a problem because we have a large county and there's lots of concerns that people have about driving around the county. So it's not like the only problem is driving to the North County. People also concerned about driving South County or Far East. But we try to recruit to the particular interest of the employee. So the right person in the right time at the right place.
All right. Look forward to it. Supervisor Lee, that's all I've got. Any comments or questions from you, or just a motion to receive the report, sir?
Yes, none from me, and we're ready to move forward on receiving a report.
All
Thank
right.
you.
I will second. I'll check with the clerk to see if we have any comment from members of the public.
We do not.
Then I'll call the roll, please.
Vice Chairperson Lee,
Aye.
Chairperson Simitian.
Aye. Motion carries unanimously. Thank you all. And please stay on time if we possibly can. And on Med Assist, Mr. Lorenz, which is item number 11, thank you for the report. I appreciate the update. And I'm pleased that we're still on track for a formal launch following the soft launch that's already underway in March. And Supervisor Lee, if you want to make a motion to receive the report, I would second that. And feel free, of course, if you have questions or comments, to make them at this time.
Yes, no questions. So moved.
Motion by Lee, second by Simitian. Mr. Lorenz, anything that wasn't in the report you'd like to say, hey, wanted to let you know?
No, Supervisor, things are progressing as reported, and we are looking to begin to aggressively improve upon our marketing efforts to inform the community about this important service.
Okay. And let me check with the clerk, see if we have any comment on this item from the public.
We do not.
Call the roll.
Vice Chairperson Lee,
Aye.
Chairperson Simitian.
Aye. Motion carries unanimously. Thank you. All right. That takes us to item number 12, which I think of as our omnibus item. And I turn to Mr. Santiago for that item and ask him to lead us through item 12 and its various component parts.
Yes, Mr. Chair and Supervisor Lee, if you desire, we can leave it up to each of you to ask any questions of our department heads. We still have the federal update. Bert Margolin is not available with us, but we do have his representative, Angie Melton from Washington, D.C., that could give us an update in terms of what's going on with the Build Better Back at the Senate.
All right, we are okay on time, not to extend unnecessarily. I think what I'd like to do, Mr. Santiago, is just say anything to share. And I'll go first to you and then to the public health officer and then to the Valley Medical Center, and we'll just make our way through it. And folks, if there's anything else you'd like to add, please do. So, Mr. Santiago, anything there?
I don't have anything to share. We do give you the data in terms of what's happening with coverage expansion. Maybe I know that Dr. Cody had to leave to attend to other matters. We could go right into VMC with Paul Lorenz, if you don't mind.
Before we do, I want to make sure that I don't skate past my colleague, Supervisor Lee, and I see that Dr. Smith has his hand up. So, Supervisor Lee, anything that you want to ask on 12A, or shall we just go to Dr. Smith?
Yes.
Dr. Smith?
I was going to go at the end, but I might as well go now. I wanted to let the committee know that one important part of our legislative initiative this year will be to get changes in the state law related to the Better Health Pharmacy implementation, because you're quite aware that currently the law requires that those services be separated from a quote normal pharmacy. We're trying to get legislation that would allow us to meld the two together so that basically all of our pharmacies, county pharmacies, would be able to offer the excess medications as part of the Better Health Pharmacy program. I'm hopeful that we'll be able to get that bill through, but we will probably have some problems with the pharmacy lobby. So at the appropriate time, we'll be asking our Board of Supervisors to weigh in at the state level.
Thank you for that, Dr. Smith. For Supervisor Lee, you may or may not know, I know Dr. Smith does, the free medication or the recycled medication or the redistributed medication effort is all pursuant to legislation that I carried when I was in the California State Senate. And my own expectation is that the pharmacy industry, at least at this point, won't be in opposition or feel threatened, but that our biggest challenge will be, as it has historically been, with the State Board of Pharmacy, who is just very, I would say, rigid in their approach to these matters. They would say cautious. And, you know, I appreciate the effort, Dr. Smith, and look forward to it. So let me then say, all right, having checked in with the director of the health system and the public health officer earlier, let's see if Mr. Lorenz has anything else he would like to share. Your chance to crow from the rooftops if you'd like to, Mr. Lorenz.
I appreciate that, Chair Simitian, and at this time, I do not have anything further to add.
All right. All right. How about Valley Health Plan? Ms. Rosas?
Apologies for the delay, Supervisor Simitian. Our focus right now is in ensuring that we are ready for the expansion for PCAP January 1st. Working really hard on that, and on the Covered California enrollment during this open enrollment period. And so those are our two main focus points.
Got it. Thank you. And let's roll right into behavioral, EMS, rather.
Good afternoon, supervisors. You have our report. If you have any questions, all providers were on time, and I would like to thank our community partners for their assistance during the Kaiser strike. All the communication was actually worked for the first time. So thank everybody. And if you have any questions for myself or Dr. Miller.
All right, I'll say I have no questions. I'll say thank you to both of you, but I will turn to Supervisor Lee just to make sure that if he has comments or questions, they can be shared at this time.
And thank you.
All right. Thank you again. Custody Health, Dr. Day, anything you'd like to share today?
Yeah, Dr. Day is not available, but I know there's a written report, and also Pratima Pandey is here in case you have any questions.
All right. I have no questions. I have the written report. Ms. Pandey, anything you would like to share before I check in with Supervisor Lee?
No, thank you, Supervisor. Thank you.
Thank you. Supervisor Lee.
None for me. Thank you so much.
All right. And then finally, we're going to get to the Margolin Group, and Mr. Margolin is not with us, but his colleague is, for a report on federal legislation that is of interest and importance to the committee and our county.
Good afternoon, Supervisor Lee, Supervisor Simitian. My name is Angie Melton, and I work in the Washington, D.C. office of the Margolin Group with Burt Margolin. He asked me to fill in for him today, and he hopes to be back for your next meeting. I wanted to check in before I went through my report and find out how we're doing on time. Do you need a really short report? Do you need a medium report? What's your time situation now?
I think a medium report would be well received.
Great. So the legislative year in DC is coming to a close. As I think you all know, the House of Representatives is in recess until January 10th, unless they are called back to vote on the Senate version of the Build Back Better Act. The Senate is still in session tomorrow and next week, presumably, and they are scheduled to be back in session on January 3rd. Know that Bert has spoken with you in the past about the Build Back Better Act. I think at the time we were calling it the Human Infrastructure Legislation. I'm going to tell you the current status of that legislation and which health-related provisions of interest to the county are currently in the bill. First, the status. As I'm sure you've all heard, what was originally a $3 trillion bill was reduced through negotiations among House and Senate Democrats and the White House to an approximately $1.7 trillion bill, which the House passed last month. The Senate is currently negotiating final language on some items and, more importantly, presenting the legislation to the Senate parliamentarians. The Build Back Better Act is being considered under budget reconciliation rules, which means that it needs only a bare majority of the Senate to pass, and it cannot be filibustered. But under reconciliation, the Byrd Rule, which coincidentally is named after Senator Manchin's predecessor in the Senate, dictates that the provisions are all budgetary in nature, either spending or saving. If the Senate parliamentarian rules that a provision's budgetary impact is minimal or incidental to the policy aim, then that provision can be struck from the bill. Senators had hoped to complete the parliamentarian process early this week, but now they are anticipating they will go into next week. Additionally, there must be a full CBO score of the legislation in its final form after the parliamentarian action before the Senate can take a vote. So Senate Majority Leader Schumer and other Democratic senators are admitting they may not be able to pass the bill by Christmas as they had hoped. Now, I'm going to give you a broad overview of the health-related provisions in the House-passed bill. Because the Senate is still working through its process, I can't predict which provisions will stay in the bill and which will be modified. I do want to note, however, that a number of these provisions would provide additional funding for the Medi-Cal program in the form of higher match rates in different areas. This additional funding was not included in the LAO budget surplus projections. So if the bill passes, it will impact the state health budget in a positive way. There will be, I guess, a higher surplus to work with. So first I'm going to talk about the Medicaid and CHIP provisions. The bill would increase Medicaid funding for in-home services. It includes $150 billion, and that would be planning grants for states, and then it would provide an additional match rate of extra 7% for states that draft new policies in that area. It also has a permanent extension of CHIP and a requirement to provide 12 months of continuous coverage for children covered by CHIP or Medicaid. It would permanently require states to cover pregnant women in full scope Medicaid for 1 year postpartum. It would also allow states to cover Medicaid eligible incarcerated individuals 30 days prior to their release. This is an issue I heard earlier discussed. Incarcerated individuals would then have a smoother path to their release. Mobile crisis intervention services were allowed in the American Rescue Plan to be covered under Medicaid. The Build Back Better Act would make this coverage permanent. There's also included in the legislation a gradual reduction throughout 2022 of the enhanced match rates that were given to states due to the pandemic. These were enhanced match rates in all of Medicaid. So the current enhanced match rate is a 6.2% enhancement. That would be allowed in the first quarter of 2022, and it would then go down to 3% for the second quarter and 1.5% for the third quarter. This glide path was included in anticipation of the public health emergency ending and wanting to allow states a gradual decrease in this match rate. Now, given the Omicron variant and the potential winter spike, this actually could be changed. They could extend the public health emergency beyond the first quarter. So I think that this enhanced match rate may stay higher for longer in the year than is included in this bill. The other thing is that this bill would provide Medicaid gap coverage for states that have not expanded Medicaid. And then it would give an additional match rate for the Medicaid expansion states. Those who have already expanded Medicaid are currently at a 90% match rate, and it would provide them a 93% match rate for the next 2 years. Other health provisions, there's an extension of the enhanced ACA subsidies, which the CBO, Congressional Budget Office, has said would reduce the number of uninsured by 1.2 million people over the next 2 years of that policy. And since the American Rescue Plan provided these enhanced subsidies, there's been an 8% increase in people enrolling in exchange plans. And there's been a great reduction in costs that individuals have to pay. And then I wanted to mention the Medicare drug price negotiation. This policy is still in flux. I know that there are still some negotiations around the policy, but currently what was included in the House passed bill would allow the Secretary of HHS to negotiate high cost drugs, starting with 10 drugs in 2025 and increasing after that. This is going to be only medications that lack generics or biosimilar competitors. It would also exempt new drugs from the negotiation process for a period of time, 9 years for certain classes and 13 years for other classes. Additionally, drug manufacturers would have to pay a rebate to the government if their drug prices increase faster than the rate of inflation. And then a really important issue is that manufacturers would no longer be able, people would not have to pay more than $35 out of pocket monthly for insulin in Medicare and private plans. The issue of private plans being covered by this provision is something that is being challenged by the Senate Republicans to the parliamentarians, so it's unclear if that's going to end up remaining in the bill. The other issue that I wanted to mention on the drug prices is that it changes Medicare Part D drug coverage to put an out-of-pocket cap of $2,000 annually for enrollees. And it would spread that $2,000 out over the year. So somebody who has very high drug costs, they wouldn't have to pay their $2,000 out over the first couple of months of the year. It would spread that $2,000 out over the whole year. And analysts have said that there are about 1.2 million Part D enrollees that in 2019 paid more than $2,000 out of pocket. So this would impact over 1 million individuals. So there's also funding to address a number of programs to address the maternal mortality crisis. So the other issues that are kind of currently under negotiation and being talked about with the parliamentarian, there is an immigration policy. They've taken 2 immigration proposals to the parliamentarian that have both been struck. So they currently have a compromise policy that would allow certain individuals to work legally in the US for a period of time. But that is being considered by the parliamentarian, and we're not sure if that one's going to go through. They are also negotiating over a change of the state and local tax deduction cap. The House passed a particular provision. Senators are redrafting that provision. So I think you can hear by my report that there are a lot of things to still be considered in this bill. So it seems very unlikely that it's going to pass before Christmas as had been hoped. But the only hard deadline for budget reconciliation to pass is that it needs to pass before the next budget resolution is passed, which is usually in the late spring, or before the next fiscal year ends, whichever comes first. So they have enough time to complete this early in the year. It just is a matter of whether they have the political will. One last issue I'd mention related to the Build Back Better Act is that the American Rescue Plan included an enhanced child tax credit that's been paid out to many individuals around the country monthly, and that enhanced credit expires at the end of the year. So the last monthly payment went out to individuals today. There's been some talk about trying to extend that in a standalone bill. Speaker Pelosi and Senate Majority Leader Schumer are not interested in doing that because they really want to put pressure on the Senate to pass the Build Back Better Act. They said that if they pass it in January, they could retroactively include the child tax credit so that there would be a seamless transition. So that's my report on the Build Back Better Act. I'm happy to entertain questions on this or any other federal issues of interest.
Thank you. Let me ask you to go back to a couple of points just to clarify for me, and then I'll go to Supervisor Lee. Ms. Melton, I want to revisit the almost first comments you made about, did I understand you to say that the House has in fact recessed, adjourned, gone home?
So they have recessed subject to the call of the chair. So they're in recess until January 10th, but they are aware that if they need to come back and vote, they will. So they actually recessed last week and they came back yesterday to vote on the legislation to raise the debt limit. So they are recessed, but they are ready to come back if something is presented for them to vote on.
That being said, the inference I drew from your earlier comments is that things in the Senate are likely to take longer than folks thought.
Yes. I think it is unlikely that the House will be back before Christmas, but they could potentially, you know, if the Senate comes back on January 3rd and they're able to get something passed that week and they need the House to come back, they might come back before January 10th if that were to occur.
All right, thank you. That's helpful to me just in terms of understanding the timing and the dynamics, which was my goal. The only other question I had goes to a comment you made about, if I understood it correctly, the enhanced subsidies for the Affordable Care Act, which I thought I understood you to say had been estimated to increase the number of insured by 1.2 million. Did I capture that correctly? And feel free to correct me if I didn't. You gave us a lot of information.
I know, I'm sorry, it was a lot of numbers. It has already increased the number of insured since the American Rescue Plan passed, but the Congressional Budget Office estimates that providing those enhanced subsidies for an additional 2 years would add an additional 1.2 million people to the ranks of the insured.
Got it. And so there is I want to restate it, and I apologize, folks, but this is a policy issue that I think is, and a financial issue that I think is important to our success in getting folks covered. So the American Rescue Act provided the additional increment in the subsidy. The additional increment in the subsidy has been acknowledged as increasing the number of folks who are insured, which is, I think, fairly intuitive. And the current estimate is that if that subsidy could be extended for another couple of years, it would generate another 1.2 million in folks who were insured in the country. Did I recap that correctly this time?
Absolutely.
All right. Thank you for your patience with that. Thank you to everyone else. Supervisor Lee, questions, comments?
Yes, thank you, Chair Simitian. Regarding the this Build Back Better, which is lasting far longer than it really should. One issue that you didn't mention, I'm very concerned about, is regarding the 2-year pre-K education that was being discussed. Has that been affected, or that's still pretty much in the bill?
That is still in the bill. I just, in an effort to not make a really, really long presentation, I included mostly health provisions. But yes, the universal pre-K is included in the bill still.
Great. So there's no effect to it, like this didn't get cut off or anything like that you know of, right?
No, not that I know of.
Good. All right. That's all I have for today. And my minor comment is I just don't know why people would like to serve in Congress when every vote you have to do, you have to physically be there. Just like this, raising a debt limit, which is one of those I call BS votes, because there's really no reason we're still playing this chicken all this time and putting the American economy and our faith and credit of the United States at risk, playing political games, which is really sad. In the meantime, I just want to make my 2 points on that, and I want to give it back to you, Chair Simitian.
All right, then I'm going to simply ask if you can offer a motion to receive the report on item 12 after I say thank you again to Ms. Melton.
Thank you very much for the great report and motion to receive the report.
All right, thank you. I'll second. We'll check with the clerk to see if there are any other speakers from the public.
There are not.
And could I ask you to scan the Zoom call here and make sure there's no one with a hand up?
There is not.
Then call the roll.
Vice Chairperson Lee.
Aye.
Chairperson Simitian.
Aye. The report is received. Motion passes unanimously. Ms. Melton, please tell Bert we wish him a speedy recovery. And with that, we are adjourned for our final meeting of the year. Take care, one and all.
Recording stopped.